Okay. Now, today's topic will be, see, I don't know whether you saw did you go through the video link which I'll send it to you, Paris? Mosen, the video nokiyairunnu anaphylaxis. I sent a link to you, video link, which I had given a talk about anaphylaxis, because this is a very, very important topic for us, especially when you give immunization. And I think none of you went through it. That will be a big mistake on your part. Anyway, we will try to go through it one by one. Okay. Now, I think, sorry, I don't know how to end meeting, leave meeting, cancel. Okay. Okay, let's start. 1, 2. If I put it here, it comes on the video. That's why I just want to minimize it. No. I think I will just minimize it. That's the best thing. All right. Therefore, we are talking about the anaphylaxis. And this is something which you and I feel we know very much about. But as it goes along, you will understand the significance of what I am telling you. This is not something which is very much discussed in the books, surprisingly, because it's so important for us. Now I'll ask you, can you read through it?
When do you suspect anaphylaxis?
Okay.
Patient is given COVID vaccine. He suddenly developed breathing difficulty and a hypotonic, no rash or itching.
Do you suspect yes or no? You answer for each sentence now. Will you suspect or not? There's no rash or itching. He becomes hypotonic and is breathing difficulty.
Yes, sir.
Okay, now read the second one.
About to give the second dose of vaccine, patient says last time when he went home nearly after 3 hours, he vomited several times and become tired. He was brought to ER and by the time he was well and active.
Therefore, was the episode that happened at home and anaphylaxis? Mosen, you are there. Can you answer? Hello?
Yes, sir. Suspect anaphylaxis.
You will suspect. Okay, go to the next one.
1 hour after vaccination, a patient suddenly collapses, comes to ER and is having pretty pulse and breathing difficulty.
No rash. Here also no rash and 1 hour has elapsed. He went home happily. Will you suspect anaphylaxis? 1 hour. No rash. Lasima, you are there?
Sir,
Yeah. Will you suspect in this condition or did you see the video which I put up here? I think none of you saw.
no.
I sent the link to you. Okay. Okay, read the next sentence.
Non-asthmatic with food allergy comes with several severe breathing difficulty 4 hours after vaccination. Do not improve with salbutamol or steroid.
Will you suspect anaphylaxis in him?
Yes, sir.
Okay, now we will go through the okay, read it now more. We will come back into the slide later to discuss it. Okay.
Which of the following is the most accurate definition of anaphylaxis? A systemic allergic reaction with only cutaneous manifestations. B, a severe life-threatening generalized or systemic hypersensitivity reaction that is rapid in onset and may cause death. C. Any allergic reaction that causes urticaria and angioedema. D. A mild allergic reaction that resolves spontaneously.
So what's the answer?
B, sir.
B.
Okay. Now, okay, we read it.
Answer B. Anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death.
Okay.
WHO position paper.
Not WHO, World Allergy Organization. Maybe paper in 2020 that is considered the latest definition. Surprisingly, that is not given the importance, but is very, very important to know what is definition. For us, what is the importance of knowing exactly what is definition? We will come to that later. But may I ask you the question here? We will go slowly on this because everything is very important from the practical point of view. What's the difference between urticaria and angioedema? Mohsen, what's the difference between how do you die? Urticaria, comes in the skin, What is that? What will be the clinical feature of angioedema?
Periorbital puffiness and lip swelling.
Oh, you are there, Rose. You have
Yeah.
joined, is it? You have come after a long time, I think. Are you seeing my videos on the site? I upload the videos, whichever you have missed. Are you going through it?
Yes, sir. Yes, sir.
Yeah. Now this topic you will understand. Even if you read 100 books, you will not get what I put up. I'll say this with importance. Now, what did you say? What is angioedema?
There will be mucocutaneous changes like periorbital swelling, lip edema will be there. In case of urticaria, there will be wheals and only cutaneous
Very
manifestation.
good. See, the angioedema is more deeper into the dermis. Therefore, what happens? You have swelling of the lips, you have swelling of the eyelid. Therefore, whenever you give something and there is urticaria, you become careful. The moment you develop angioedema, it is still not anaphylaxis. Remember that. The moment he has breathing difficulty, that is laryngeal edema, it becomes anaphylaxis. Therefore, remember in urticaria and angioedema, it is still not anaphylaxis. Why I'm telling you this is the moment you diagnose anaphylaxis, that means the child cannot receive that vaccine forever. Therefore, you have to be very careful in the diagnosis. Now, this diagnosis of 2020 paper is the latest, but we will come to that later. Okay, now read it. Okay.
Which of the following statement about anaphylaxis is true? A. All cases of anaphylaxis present with hives or itching. B. Cutaneous symptoms are absent in approximately 10% of anaphylaxis cases. C. Anaphylaxis always involve hypotension. D. Skin involvement is required for diagnosis.
The mainly question is, what is it? The answer?
D.
Anybody can
D.
give? Yeah?
B.
Okay. Now read the answer.
Answer A. Cutaneous symptoms, most commonly urticaria or hives, absent in around 10% of anaphylaxis reactions.
Okay, this is very important. That the problem is, why is it absent? Because it may not develop immediately. The patient may go into hypotension, and after half an hour, he may develop the urticaria. Therefore, you should be able to diagnose anaphylaxis even without that. Okay.
A 5-year-old child receives a COVID-19 vaccine and suddenly developed respiratory distress and hypotonia within minutes. There is no rash. What is likely diagnosis? A. Vasovagal syncope. B. Anaphylaxis. C. Acute asthma exacerbation. D. Panic attack.
One more thing they could have put is hypotonic, hyporesponsive event, which they have not put up. But hypotonia is one feature of it. We will come to that later. Your answer is B, is it not? Anaphylaxis straight away. Now we will come to the definition. Okay, how do you define Now, the thing about this I want to tell you is the purple book of anaphylaxis, which you give immunization, doesn't deal very much with anaphylaxis. I think there's no topic like that only. The pink book, the previous one, 2016, gave the definition which was there in 2011 World Allergy Organization. That's what WAO. But what we are current is the definition of 2020. Now read it.
Definition: anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. A severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, and/or circulation, and may occur without a typical skin features or circulatory shock being present.
Okay, now we will go into the, see here, you have to know certain things. Serious systemic reaction, that's a very important thing. Hypersensitivity, you can have allergic reaction, that's a serious. What is serious, we'll come to that. May cause death. It need not cause death. You remember this. Because many times when mothers come and say, we were given injection at, then develop a collapse in the A&M gave, and after some time he woke up, we will say it is vasovagal syncope, because if it was anaphylaxis, it would have caused death. No, it is a serious systemic disorder which can characterize by potentially life-threatening compromise, potentially life-threatening it only. It doesn't mean that it need cause death. Remember this, serious systemic reaction that is usually rapid in onset. Every word is important here. It is potentially life-threatening, not life-threatening. Now, there are so many definitions. Therefore, if you look at 2011, a serious life-threatening reaction, serious life-threatening reaction, it's only life-threatening that they have written. Therefore, the WHO has also referred it as a serious life-threatening systemic hypersensitivity reaction. Life-threatening, it is not fatal disorder like that. Now, there are myths and facts, controversies. Many people, even the pediatricians, have many different opinions. This is taken from the art. Look, this topic I have researched extensively. I talked up from archives. I've taken up from up to date, but one article I missed. I'll tell you about that later. Therefore, it is taken from multiple sources. Now, can you read it?
Anaphylaxis often result in death. Anaphylaxis can be life-threatening, but in reality, the majority of the reactions do not result in severe outcome. Many reactions are not treated appropriately, yet fatal anaphylaxis is a rare event, with a case fatality rate under 0.001%.
Okay, now this is a myths and facts, controversies in the diagnosis of management. The first myth is anaphylaxis often causes death. Okay. Last sentence.
Severe anaphylaxis, however, is unpredictable, and a severe reaction may mimic more mild anaphylaxis reaction in the first instance.
And now this is the most crux of the matter. Yes, anaphylaxis is very, very rare to cause not 0.001%. That's why we have not been in trouble very much. Many of the pediatricians don't care whether the adrenaline is available in our emergency. Our health service doesn't bother whether the A&M who goes and gives the vaccine in the knows to treat or is capable of giving an adrenaline. Or does he carry an adrenaline? Nobody knows. Even if she carries, is he entitled to give an injection adrenaline? Is she told? Nobody bothers. Because all this is because it is very, very rare. But remember one thing, that is unpredictable. See, the first thing what happens in anaphylaxis may start off with a small rash. If you are ever called for an allergic reaction for after vaccination, stop everything else. Be with the patient unless you are sure. You understand? I'll tell you why it is. It's very, very rare to cause death, but when it causes, probably the problems can be so severe, especially if you are not given an adrenaline. Therefore, the question is, when will you give adrenaline? That's the problem. Okay, now next.
Therefore, the majority of anaphylaxis reaction cannot be described as life-threatening in themselves. Given our inability to predict the reaction progression, it is emphasized that all anaphylaxis reaction must be appropriately treated with intramuscular adrenaline to help reduce the risk of death.
This is very important because if you are not given adrenaline, you have not treated anaphylaxis and it can have medico-legal problem. Once you have labeled it as anaphylaxis, the child cannot receive any more of that vaccine. That's an absolute contraindication. Therefore, your decision is very, very crucial. Therefore, that is what will come up in the later stage. Okay. Now we will look at the definition of NICE and other thing. Okay, read it.
Anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitivity reaction. It is characterized by rapidly developing life-threatening problem involving the airway, that is pharyngeal or laryngeal edema, and or breathing, bronchospasm with tachypnea, and or circulatory hypotension and or tachycardia. In most cases, there are associated skin and mucosal changes.
Okay, now, but I just put up the NICE guidelines. That's okay for people who go for MRCP exam. That's all. Is due in December, but updated in 2020 by the NHS. Is a severe life-threatening generalized or systemic reaction. Okay. Now the problem arises in the emergency department. Why I put up NICE guideline is because they have given something. Now read what is coming up in your this one.
In emergency department, a person who presented with signs and symptoms listed above may be classified as having a severe allergic reaction rather than an anaphylactic reaction. Throughout this guideline, anyone who presented with such signs and symptoms is classed as experiencing a suspected anaphylactic reaction. People who have had a mild or moderate allergic reaction are at risk of and may subsequently present with suspected anaphylaxis.
Now, why I put up this? Normally, don't put up the NICE guidelines. This is the as of August 2025. That is when I am presenting this, the latest NICE guidelines. I like this because when you go to an emergency, you see a patient with fever and rash, and the patient doesn't fulfill all the thing of anaphylaxis. Sometimes you cannot but give the adrenaline injection. When you give the adrenaline injection, the patient, everybody would say yes, therefore it is anaphylaxis. I would also have said this before. But the point you should realize is there are conditions in which it may be a suspected anaphylactic reaction. Somebody may say there is nothing like that. You can say the NICE guidelines gives that because there's a very functional diagnose at that point of time. Later you go back and think, am I to label this as anaphylaxis? Because you label it, the child does not get that immunization. It's a full stop on his immunization. Remember that. I attended the KIMS meeting, and somebody, allergologist from Madras, came and said he was keeping on telling, suspect, give adrenaline. Suspect, give adrenaline. I rose up and asked him, you are telling as an allergist, do you know what the consequence is for the child? You suspect and you give adrenaline, then nobody will immunize the child afterwards because you have seen an anaphylaxis to that particular medicine. Therefore, there is something called severe allergic reaction. There is something called suspected anaphylactic reaction when we go along. This is only given in NICE guidelines, but don't quote it in your exam. I'll tell you what to say is what is the best definition, which is best for us as we go along. Can you go ahead now? Yeah.
Myth, there are no hives, so it can be anaphylaxis.
Okay.
Cutaneous symptoms, most commonly urticaria or hives, absent in around 10% of anaphylactic reactions and were present may be delayed in onset.
Yeah, that's around very important. Only 10% may be delayed. Okay. Now we come to the definition. Therefore, Therefore, we come to a serious hypersensitivity reaction, may cause death, need not cause death, potentially life-threatening. That's all these are very important, with or without. Now, you might think that the anaphylaxis diagnosis of WHO, WAO, you keep quoting it, keeping studying it, quoting it. From the practical reason, this is not what is given in Nelson, if I am right. Now, we'll come to that later. Read it now.
What is the first line treatment for anaphylaxis? A. IV hydrocortisone. B. Nebulized salbutamol. C. Intramuscular epinephrine. D. IV diphenhydramine.
What is it?
C. Intramuscular epinephrine.
Yeah, intramuscular epinephrine is the treatment of anaphylaxis. Epinephrine is the first treatment according to all guidelines. Remember that why it is so, it will come up later. It is very simple said. Rose, you agree? You are there?
Yes, sir.
Yeah, you agree? See, let me tell you one thing, that 2 or 3 cases which happened in our own hospital when I was there, epinephrine was never given, even by consultants. What is the reason? I'll tell you as it goes along. You will all agree, first thing. But what doctors do is, well, this doesn't, the rash is coming up, child is having some breathing difficulty. Let's give a salbutamol. Let's give a what they call the intravenous antihistamine, like that. People are afraid to give epinephrine. The reason is multiple, because by the time the patient collapses, usually heart rate will be very high. It will be 200, 100, 120. Some people worry, how can you give epinephrine to a child with so much heart rate? These are, and many other reasons. Other reason is when we were students, benzathine penicillin was given for rheumatic fever, and sometimes they collapse. And many of these patients have heart disease. Therefore, the doctor will not give adrenaline because it's a known heart patient. Now, may I ask you, Rose, one question? Suppose you have a child, usually it happens in adults. You have a heart disease patient. He's on anti-medical drugs for, say, myocardial infarction, or he's in cardiac failure. He develops an anaphylaxis. Will you give epinephrine or not?
We'll give you epinephrine.
Yeah, there is no contraindication. Remember this. In the setting of an anaphylaxis, to give epinephrine. And if you are not given epinephrine, you have not treated anaphylaxis. And if the patient dies, it's a huge medical legal problem for you. And remember that whenever you send your patient health workers now for outside, I am telling to Dr. Faris and Dr. Amal, you have joined the health service in a health center, buy from your own pocket adrenaline and give it to them. Now, the question is whether they can administer it. Nobody answers it. We'll come to that later. Okay.
A child presented with stridor, vocal changes, and odinophagia after eating peanut. What is the primary concern? A. Laryngeal edema. B. Gastroenteritis. C. Foreign body aspiration. D. Epiglottitis.
Unfortunately, I gave the answer also in that. Okay. Can you tell me? What? The answer is, yeah,
Laryngeal edema.
laryngeal edema. What is odinophagia?
Difficulty in painful swallowing.
What is adenophagia? Can anybody say?
Painful swallowing.
Huh?
Painful swallowing.
Yeah, very good. Painful swallowing. Therefore, what happens is, if after eating something he suddenly develops, you will think that is a foreign body aspiration. Remember that it can be laryngeal edema. It can be one of the signs of this also. Therefore, now we will go into very carefully what is it. Now, you will have to read this in full. Okay. Can you read it?
Anaphylaxis is
Yeah.
likely like when one of the following two criteria are fulfilled. First one, acute onset of an illness, minutes to several hours, with simultaneous involvement of skin, mucosal tissues, or both. Example, generalized hives, pruritus, or flushing, swollen lips, tongues, uvula, and at least one of the following: a respiratory compromise, example, dyspnea, wheeze, bronchospasm, stridor, reduced PEF, hypoxemia. Reduced BP or associated symptoms of end organ dysfunction. Example, hypotonia, collapse, syncope, incontinence. C. Severe gastrointestinal symptoms. Example, severe crampy abdomen pain, repetitive vomiting, especially after exposure to a non-food allergen. Second point, acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, minutes to several hours, even in the absence of typical skin involvement.
Okay. Now, what it comes up here is that there are two things you have to understand. This slide, you have to be very careful. First, they are telling it as only highly likely. Okay. Highly likely. Sorry. Yeah, here, highly likely. They are not telling diagnostic because remember, anaphylaxis is a clinical diagnosis. Even then, the definition only gives you what is highly likely. Remember that. They are divided it into two things. One, when you have rashes. Two, when you don't have rashes. Okay, that's very important to understand that. And uh, then you have to remember that it can happen within several hours. Remember that minutes to several hours. You give an injection. How long will you ask the patient to be in the OPD? Have you ever seen any of your consultant, boy, injection, go and take the injection? After that, how long does the nurse in PRS hospital ask the patient to wait? Any idea? Lasima, are you there?
15 minutes.
15 minutes. Rose, how long do they ask to wait in your hospital? Do they at least ask them?
30 minutes, sir.
30 minutes. Okay. Yeah, it is true that 15 minutes, 30 minutes, 45 minutes, even then, you must tell the patient when he goes, root down the 5 vitals, tell the patient that for several hours, if there is any symptom, please come back because the reaction, even anaphylaxis, can come back after some time. Therefore, there are two types here with skin rashes, then skin changes, then you can have only one of them: respiratory compromise, hypotension. And what is surprising to me, what really surprised when I first read about it, is the gastrointestinal symptoms. What is severe gastrointestinal symptoms? They are telling crampy abdomen pain, repeated vomiting. Therefore, if you have given a patient an injection, he develops hives and he starts vomiting severely, that is anaphylaxis. Even if the respiratory symptom is not there or the reduced MP is there. Okay, that is one thing. The second is when there is no rash, it need not be. Any onset of hypotension, bronchospasm, after exposure to to a known or a highly probable allergen. The problem is what is known for that patient. Probable allergen for that patient. That means the patient says, I am what you call allergic to peanut, and he takes a peanut and he develops hypotension. That is enough. That's understandable. He takes a peanut and he develops a bronchospasm. That is enough. Allergy. That's all that is required. Is a known, highly probable allergen. But what are the highly probable allergen for that patient? Anyway, we will come to that within minutes, to even in the absence of typical skin involvement. And what are the symptoms of laryngeal involvement? This is something which may not strike you. What is our features is, therefore, this important definition. And what is laryngeal involvement? How will you make a diagnosis? Who else? Mohsen, can you tell me? Mohsen is there, as usual, gone. Lasima, you are there? Hello? Paris, where are the other people gone? They checked in and went away. Huh? Okay, Rose, can you answer?
Strider, sir.
Yeah, this is not only stridor, vocal changes, odonophagia. Now, stridor means, of course, everybody knows that stridor you will immediately diagnose because it becomes a respiratory bronchospasm or respiratory income. Vocal changes means his voice changes. He's not able to talk. He's pointing to your neck. What will you say? Page boy. I mean, he's functional. No, remember that. It can be is stridor involved. Odonophagia, you may think it is aspiration of the foreign body. No, it can be anaphylaxis also. I don't know how much of you knew about it. I was not aware when I read this till about 4 or 5 years ago when I first read the definition. I was surprised. Therefore, if you give an injection and the patient suddenly stops talking and he stops pointing to your neck, I have seen one child like this. I never diagnosed stridor. I never diagnosed his anaphylaxis. He became all right, and we said that it was functional, or he became afraid. But now looking back, probably it was an anaphylaxis which is cured by itself. Therefore, vocal changes and stridor are important changes. Therefore, remember this: hypotension, bronchospasm. All of you will remember. But if there is a two definition: one with rash, the other when there is a probable or a highly probable antigen or not. Now we come to what is the definition given in, I think, in the standard treatment guidelines and the Nelson's test book of pediatrics. I find it more practical, actually, and we cannot ignore it because it's given in Nelson. And I think it's not the World Allergy Association definition. Rose, can you read it? Hello?
Anaphylaxis is
Yeah.
highly likely when any one of the following three criteria are fulfilled. First,
Okay.
acute onset of an illness with involvement of the skin, mucosal tissue, or both, and at least one of the following: respiratory compromise or circulatory compromise. Second, two or more of the following that occur acutely after exposure to a likely allergen for that patient. A, involvement of skin or mucous tissue. B, respiratory compromise. C, circulatory compromise. D, persistent GI symptoms. Third, acutely after exposure to a non-allergen for that patient. Reduced BP defined as low systolic BP for the age or more than 30% decrease in systolic BP.
Okay, therefore,
Ac-
yeah. See, what they have done is they have classified into involvement of the mucosa at least one of the following: respiratory compromise or circulatory compromise. What is missing here in all this? Okay, I'll come to that. Huh? In the previous definition, acute onset of illness, respiratory compromise, reduced BP, gastrointestinal symptoms. Here, respiratory system and circulatory compromise. There seem to be no gastrointestinal involvement here. But here, two or more of following exposure to a likely allergen. Okay, therefore there's a slightly difference: respiratory compromise, circulatory compromise, or persistent gastrointestinal symptom. Therefore, and the third is known allergen to that patient. Okay, here it is. Therefore, there are subtle differences if you go. This looks looky to me. If a patient, say, for example, I'll tell you, I have a patient who is said that measles injection last time at 9 months, I developed some reaction and the doctor treated. You give MMR at 16 months and the patient develops BP. That alone may not be fulfilling the diagnosis of an anaphylaxis, but you will immediately treat him as anaphylaxis because he's a known to that patient. Here, exposure to a likely allergen for that patient, like peanut, etc. There, for that patient, two or more. Here, skin, respiratory, circulatory, or gastrointestinal symptoms. Two symptoms should be involved. And if the onset of illness, involvement of skin and mucosa, at least one is enough. But in that, they have not given gastrointestinal symptoms. Now, what is a persistent gastrointestinal symptom is a question. If the child has nausea, will you call it persistent? No. Severe vomiting, etc. only you. And that is not taken into consideration for patients with food allergy. If you have food allergy, you definitely will have. For which definition will you work up is a question. There are subtle differences between these two. When studying both will be is good, because one is what is surprisingly missing in the diagnosis of Nelson is what? I mean, there are confusing things. I would advise you to read it, this study. Unlikely that your examiner will ask you word allergy association diagnosis, but there is something missing here. What is that? Rose, can you say? From this definition to this definition. Laryngeal involvement is not here. Am I right? Therefore, in the definition of this one, Nelson, which is given in the standard treatment guidelines of IAP in 2022 also, there seemed not to be the laryngeal involvement. Therefore, I would advise you to follow this, but remember that word laryngeal involvement is a very important thing, because this is more practical. If you have an acute onset of an illness with involvement of the skin mucosa and then he develops respiratory or circulatory compromise, yes. And then if he has occurs likely exposure to allergen respiratory, here also I think gastrointestinal should come. But if he's a known allergic, he develops a peanut allergy, he takes peanut, he collapses in front of you or anything, he develops a rash even very rapidly, he is becoming uncomfortable, you better treat it as anaphylaxis. Okay. After exposure to a likely allergen, exposure to a known allergen. Look the difference here. Here you require 2 or more criteria of the following when is exposure to a likely allergen. Here it's a known allergen. Likely allergen is peanut, tree nut, and other cow's milk, etc., egg, etc. Here known allergen is, then you need have only one criteria. Now, the question I am asking is why there is no mention of the laryngeal involvement in this definition. Now, WA position. See, the key to diagnose involves pattern of recognition also. Sudden onset of signs within minutes to hours after exposure, known potential, often followed by rapid progression of symptoms. Once it onset, the symptoms progress very rapidly. Therefore, that is also a key to diagnosis when you are suspecting. Let me tell you one thing. When a child develops a reaction, it's highly charged atmosphere there. The patient starts blaming the nurse panics, everything. Therefore, you must make a decision within minutes. Can you read it fast now?
Some definitions implies the need of multiple organ involvement. However, severe symptoms can present in only one organ system.
Okay.
Such a definition is misleading and can lead to inappropriate treatment.
So when do you suspect? When do you suspect these? Which will you suspect?
When do you suspect anaphylaxis?
Well, okay,
Child is given...
we have read this all through. My question to you is, when do you suspect, when do you not suspect? Child is given COVID vaccine, he suddenly develops breathing difficulty and hypertonic. Do you suspect? No rash. Mohsen, you are there?
Will suspect.
Will suspect. Second, about to give the second dose of Covaxin. Patient says last time he went to home nearly 3 hours, vomited several times and became tired. Will you suspect?
Yes, sir.
You will suspect. After vaccination, 1 hour suddenly collapses. 1 hour later, comes to ER and having 30 pulse and breathing difficulty. Do you suspect?
Yes.
sir.
Yes, in all these situations, actually, non-asthmatic, the biggest mistake you can make is patients with food allergy may come to you, or non-asthmatic may come to you with, they are atopic patients. They come to you with asthma, severe breathing difficulty in the ear. Does not improve with salbutamol and steroids. You must how many times this has happened, and you would start magnesium definitely. But does it ever cross your mind that this can be anaphylaxis? Now, my question to you, Rose, is if you see a patient in the ER, many times they would say, Doctor, we went to the health center, we gave them salbutamol. Everybody gives salbutamol now. And 3 times, and the patient is severe, is not improving, it's not like before, he has become very sick. Therefore, they have advised us to come to your Aster because they want to give magnesium and you can admit in the ER, in the ICU and give it. How do you know whether this child has got asthma or anaphylaxis? Acute severe asthma or anaphylaxis?
The acute severe asthma child will be responding well to the nebulizations.
That's not always, is it not? Sometimes it doesn't. That's why they refer the patient to you. They might partially respond and they may go back into severe. Sometimes 3 nebulizers don't help. That's why when you start thinking of giving IV magnesium, motion is there or gone forever. Paris, who all?
Other systemic involvement.
What is it?
Hypotension and other features will not be present.
Hypertension is a very important thing. That's why I keep telling again and again. Every asthma patient who comes to you, please take the blood pressure. Take the blood pressure. If there is hypotension, immediately suspect that it is an anaphylaxis. You may get one case in all your lifetime of practice, but that will be life-threatening. And when you suspect, you give the adrenaline. That's another thing. Any other symptom which would make you think that it is anaphylaxis? The other symptom which should make you think as anaphylaxis is vomiting. If the child has got persistent vomiting with asthma, with acute severe dyspnea, you should immediately think that it could be severe persistent gastrointestinal symptoms are not a feature of acute asthma. Remember this, but they are of anaphylaxis. Therefore, whenever you see a patient who's not developing, you would take a BP in patients before you give magnesium, I know. Therefore, if you see hypotension before giving magnesium, immediately suspect that. And when you suspect anaphylaxis, give the adrenaline. Okay. Now we go back. Go
Which
ahead.
of the following common misconception about anaphylaxis management? A. Epinephrine should be delayed until diagnosis is confirmed. B. Antihistamines can be used initially. Epinephrine only if symptom worsen. C. IV fluids are contraindicated. D. Oxygen should be avoided.
What is it?
Epinephrine
Yeah.
would be
Who's answering this?
All of them.
No, which are the common misconception is wrong.
epinephrine should be delayed until diagnosis.
Yeah, that is the one probably they are telling antihistamine can be used to treat anaphylaxis initially. Epinephrine only needs symptom worsen. This is a myth. You understand? The main basis or problem of anaphylaxis is epinephrine. The earlier you give, we will be coming into the full discussion about that. Okay, and A should also be correct. I have written epinephrine should be delayed until diagnosed, confirmed, but I'm not too sure. When you suspect, you should give epinephrine. I don't know why I myself had the same doubt in it, but we will come into a full discussion on that. That's the core. The decision to give epinephrine is very important. Okay, you cannot wait till the diagnosis is confirmed. Remember, therefore, that is a wrong. Anyway, should also be correct. You're right, but never antihistamine initially. epinephrine only if symptoms worsen is a wrong statement. We'll come to that as we go along. Remember. Now, can I read the whole thing?
Antihistamines can be used to treat anaphylaxis initially. Epinephrine is only needed if symptoms worsen. Histamine is
Yeah.
only one of many inflammatory mediator released during anaphylaxis. Oral antihistamine take around 30 minutes for onset of effect. Intravenous chlorpheniramine has a faster onset but can cause hypotension. Antihistamines are not effective against anaphylaxis. Prophylactic use does not prevent anaphylaxis.
Okay, just before you give, some people say, okay, he has got allergy, let's give antihistamine and then give the medicine. No, prophylactic use of antihistamine does not prevent anaphylaxis. Okay, these are things. Now there are 10 myths which are given in the this one, which is worth reading in it. Now, you can read it because it's worth it. This given from an archives article. You may know some of this, but you can read. Now, Faris is reading everything. Mohsen, can you read it? Mohsen, you are there? People just are not there, I think. Who else is there? Lasima, you are there?
Sir, Gopika.
Oh, Gopika, you read it. Welcome. So happy
No,
birthday, huh?
belated, sir, yesterday.
Yesterday, I know, but I saw it only today. Okay.
Thank you, sir.
Okay. So you have become 20 years old, huh?
I wish to.
Okay, read through it now.
Sir, should I read everything, sir?
I think it's worth it because this is a very important fact which is not given anywhere else. Therefore,
Okay.
read it very fast.
Okay.
Sorry, my daughter is there. Then. Okay, read it, no problem. Okay, if you have a problem, I will ask Rose to read it. You mute it there. Rose, you read it.
The common misconception in anaphylaxis and what current evidences reveals. Myth 1. Anaphylaxis often results in death. What evidences tell us? Anaphylaxis can be life-threatening, but a majority of reactions do not result in severe outcomes. Myth 2. There are no hives, so it can't be anaphylaxis. Cutaneous symptoms, most commonly urticaria or hives, are absent in around 10% of the anaphylactic reactions. Myth 3. No trigger for the reaction is identified, therefore it is not anaphylaxis. In around 20% of the cases, no trigger is identified. This is known as idiopathic anaphylaxis. Myth 4. Epinephrine is dangerous. Epinephrine given by intramuscular injection into the outer mid-thighs is very safe. Myth 5. Antihistamines can be used to treat anaphylaxis initially. Epinephrine is only needed if the symptoms worsen. Epinephrine, not antihistamine, is the first-line treatment for anaphylaxis. Myth 6. Corticosteroids prevent delayed or biphasic reaction in anaphylaxis. There is insufficient evidence to support the use of steroids to prevent or delayed or biphasic reactions in anaphylaxis. Myth 7. Only children who have had an anaphylaxis needs an epinephrine auto-injector. It is very difficult. It is not impossible to accurately predict who is at risk of severe anaphylaxis. Myth 8. Epinephrine auto-injectors are overprescribed and overused in anaphylaxis. Auto-injectors are overused to treat anaphylaxis in the community. Myth 9. Prescription of epinephrine auto-injector is in isolation is life-saving. Optimal management of food allergic patients and treatment of anaphylaxis has many phases and is not limited to prescription for epinephrine auto-injector. Myth 10. MMR and influenza vaccines are contraindicated in patients with previous anaphylaxis to egg. Both the vaccines are safe to administer in egg-allergic children, including those with previous anaphylaxis.
Okay, now these are, I don't know where, therefore remember this. Previously it was said if you have hives after giving, if you take egg and just develop rashes, you can give. If you develop anaphylaxis, you cannot give MMR and influenza. Now it has been clearly said, even if you have anaphylaxis to egg, you can give these vaccination. Previously, it was said till recently, till 1 week back, it was still yellow fever is contraindicated if the patient has got anaphylaxis to allergy. Now it has come about, it can be given. Now here, two things I would like you to note. No trigger is identified, therefore it is not prophylaxis. Remember, you should suspect anaphylaxis whenever you have a hypotension, which is not responding to your treatment, whatever be the condition, even if there is no trigger. How many of you give it is simple. Now, epinephrine is dangerous. Let me tell you this very important. Many experienced pediatricians don't give epinephrine on time. Why? If you ask them, they will give you many things. We didn't think it was anaphylaxis. We thought it was an allergic reaction. He's a known asthmatic, therefore he probably had asthma. Or they thought that the most important reason given in is that especially asthma patients, you would have given already nebulized salbutamol, and then that might be the reason why he did not give. That can be the reason why you did not give. By one myth, one question which is not raised in this this article in Archives, which came in 2018, I was very impressed by that. But one question which is often asked is, can the second dose of a vaccine produce anaphylaxis when the first dose was safe? That's my question.
Yes,
Oh,
sir.
huh? It can?
Can.
Yeah. What about our PRS people? What is Faris telling? What's your opinion? The patient comes, he has taken the first dose of DPT in your or pentavalent in your clinic in PHC. The second dose, he develops some reaction. Can it be anaphylaxis to pentavalent vaccine?
Yes, sir.
It can be. Okay, how come? Why didn't the first one produce? Actually, this is an IgE mediated. There are two types of reaction, IgE mediated and non-IgE mediated. IgE mediated tends to occur immediately within 30 minutes. And for that, you require sensitization. Therefore, UpToDate goes to the extent and says if the first dose produces anaphylaxis, it is not due to the vaccine itself, because the vaccine you are coming into contact for the first time. It may be due to the gelatin or the antimicrobials or the thiamerosal which is present in that. I will present it definitely. Therefore, definitely remember, if the parent says, this is the third dose, doctor, how come I have taken it before there was no reaction? Yes, the second or the third dose can produce anaphylaxis when the first dose doesn't. Remember, another very important thing, why there is no, remember this, these are called what you call medication or which can produce a anaphylaxis mechanism triggers. Therefore, what would happen is if you are emotionally stressed, suppose you are allergic to peanut, you may have taken peanut many times, once in a while you have developed a rash. You are emotionally stressed, you may develop anaphylaxis. Another is, surprisingly, after exercise is another stress. After exercise, you come home and take a fruit juice or you take a fruit you are allergic to, previously only rash, this time it might be anaphylaxis. Now, this is a question where he asked the on first exposure, because this is a typical, I asked the chat GPT because it's a very important question. There are articles in CDC and JAMA which shows that you can develop a reaction in the second one when the first one did not reduce. And later, surprisingly, when I read UpToDate, I was surprised to find that they say that if you developed on the first attack, it is usually not due to vaccine, but due to the preservatives in that, because you are likely to have contact with the gelatin, or you are not likely to develop an IgE mediated reaction in the first attack, first exposure to the vaccine. Which type of immune reaction can you develop to the first time itself? We have got 4 types, isn't it? Type 1, type 2, type 3, and type 4. Which type of immune reaction can you develop in the first inborn? It is type 3. Okay, now read on now. I think Who's going to read? Yes?
A patient on beta blockers develop anaphylaxis unresponsive to IM epinephrine. What is the preferred alternative? Glucagon, atropine, dopamine, adrenaline drip.
Yeah. There's something which is, which if you have seen my video only, you would have got it. Beta blockers are a common cause of hypertension. Remember that, it's widely used. Rose, did you see the video which I sent the link? No. You didn't get time, is it?
Uh,
I sent a link of COVID the vax to you. Anyway, answer.
Glucagon in patients on beta blockers.
The answer is we have given this anaphylaxis emergency treatment. Along with this, you will give albuterol, antihistamine, ranitidine you can give. But adrenaline is the first treatment. But if it is, you have patient is on beta blocker, you can give glucagon. Don't ask me how it is. I was also a little surprised at that. Okay.
Which position is
Yeah, who's reading? Mohsen, you read that.
Which position is recommended for children with anaphylaxis unless contraindicated? Sitting upright, Trendelenburg, supine, prone.
Yeah. So much difficulty, huh?
Trendelenburg?
Okay. All right, we will come into a discussion quick in that. Remember.
Most patients answer C, supine. Most patients should be placed in supine position during anaphylaxis unless there is respiratory distress.
Okay, Dr. Faris, how do they give the PRS hospital injection? When they give the injection on the mother's lap, on the mother's shoulder, or on the cot? Where do they keep the patient? Very, very
Mother's
practical. Mother's lap you can give or on the cot, but never on the mother's shoulder. Never upright. Remember this. And whenever you give to an adult, at least make him sit. At least. Don't give him when he's standing. All right?
In a pregnant patient with anaphylaxis, what is recommended positioning? A supine, sitting upright, left lateral, semi recumbent Trendelenburg. Answer C.
Yeah, yeah.
If a pregnant,
They gave the
Post-
answer also. Patient that is on the pregnant, it's C, left lateral recumbent position. See, now read it. This is given in the WHO position paper, WAO position paper. I have put it up in this one. Lasima is there? No? Okay, Rose, you read it.
Most patients should be placed in a supine position during anaphylaxis unless there is respiratory distress, in which case a sitting position may optimize respiratory efforts. If pregnant, position the patient in a semi-recumbent position on left side. If unconscious, place in recovery position.
What is the recovery position is given very clearly here. Hands, see, one hand supports the head and the knees stop body from rolling over. Why you keep the knee like this is he shouldn't roll over. Therefore, this is Pals would have taught you very well this. What is recovery position? But that's not the position in which we keep patients with anaphylaxis. Now to Rose's answer, read it.
The benefits of elevation of lower extremity Trendelenburg position is controversial.
This is not allowed, okay? But Rose, you're probably right. Now I'll ask you this question very practically. You are there. The patient is, you are in the emergency. You are called to the immunization room. The nurse says, I gave him an injection. The child is looking child is looking pale and his pulse looks little thready. You have just reached the place. Okay, what will you do immediately? What will be your course of action? There will be chaos. The mother will be worried. Mother will say the nurse has given the wrong injection because he had taken this injection previously. A very charged atmosphere. What will you do first?
I will keep the child in supine on the bed and check the vitals,
Okay,
including the blood
supine on the
pressure.
bed, but raise the legs. Okay, it is not because it is anaphylaxis. I mean, it may be worth. And then what will you say? You feel for the pulse is steady. Now, if you plan to take BP, you will lose time. Ready? Mom, probably he has got hypotension. And what will you do? At that time, particularly, yeah,
Administer IM adrenaline
okay. Call for
on left
adrenaline.
lateral.
Sister, I want adrenaline. I want help. That's the two things you want. Call your consultant. Call the bleep. Call your what you call blue code or something. You call. But what will you do immediately? You will raise the leg. Okay. Probably it's not given here. It will come up later. Suppose a child within 2-3 minutes suddenly cries and sits up. What is your diagnosis?
Hypotonic hyporesponsive episode.
Well, it's very rare. What's the most common?
Vasovagal syncope.
Vasovagal syncope. Remember that. If you have put the patient on the supine, raise the leg, nurse, bring the adrenaline, 0.15 ml. That is what you will have to give below 6 months per child. By the time she takes it, if she has, we will come into that 0.15 ml is not easy. By the time she takes it, some time will go. By the time the child is okay, put him on right and say the diagnosis vasovagal syncope, because he will recover within no time. Therefore, benefit of lower extremity exposure if in a diagnosed case of anaphylaxis, questionable. There's nothing wrong in doing it, but better do it when you see the patient raise it, supine position, and raise the leg. Okay. Go ahead.
When should a serum mast cell tryptase level be drawn in suspected anaphylaxis? 6 to 12 hours after the symptom onset, within 15 to 180 minutes, only after 24 hours, at any time during hospitalization.
Didn't see the video. Okay.
15 to 180 minutes.
Yeah, this is, I don't know whether it is taken in Aster. You can ask them, because this has, in the Western world, it has got medical legal significance. Remember this. You cannot escape it. You finally say that the patient died due to or became sick because of anaphylaxis. They might ask you, did you take the serum mast cell tryptase? 15 to 8. You have till 3 hours to take it. Therefore, if a patient develops, when you treat him, treat the blood for mast cell tryptase also, because that measures. Read it now.
Lab investigation. A clinical diagnosis measuring mast cell tryptase may be helpful where the cause of reaction is unclear. A serum sample should be collected within 15 to 180 minutes of symptom onset, with a further convalescent sample at least 6 hours later. It's non-specific.
Yeah, it is written in our book as it is non-specific. But if you go and read CDC and other books, they would insist on taking it because all these are got medical legal significance. Okay.
Which of the following is not a typical feature of anaphylaxis? Bronchospasm, hypotension, pallor and sweating without other symptoms, angioedema.
What do you think? Which is
Pallor and sweating.
Yeah, pallor and sweating without other symptom. You see, we will be discussing it as we goes about. Pallor, when we give the injection, the patient becomes very pale. Anybody who becomes pale and suddenly collapses is usually vasovagal syncope. In anaphylaxis, flushing occurs and pallor occurs at the last. We will come into that.
Um,
Yeah.
Syncope is relieved by recumbency and is usually associated with pallor and sweating and absence of urticaria, flushing, respiratory symptoms.
Okay.
A child with a non-asthma develops severe respiratory distress 4 hours after vaccination, unresponsive to salbutamol and steroids. What should be the next step? Suspect anaphylaxis and administer IM epinephrine.
Okay, now you see, let me tell you one thing here. With when Gopakumar, where he was here, you would have seen in bronchiolitis. I mean, in many patients with asthma, he will give adrenaline. Whether adrenaline is given there for asthma, not for anaphylaxis in this one. Are you giving adrenaline for asthma in PRS hospital, Doctor? No.
No, sir.
Who's this Faris? Okay. What about Rose? Are you giving it there?
No, sir.
Yeah, but surprisingly, I was asking Gopakumar why you're giving epinephrine. Well, he said that is often given in Calicut, is given in even in KIMS, I think he said like that, and he used to give epinephrine whenever the patient was no. I don't blame him because epinephrine is the most powerful bronchodilator known yet. That's what Harrison has written, but it is very short acting and it's given subcutaneously. Remember, for asthma, anaphylaxis is given IM. Remember that. And for when adrenaline is given for cardiac arrest, the dose is different. Remember that also. Therefore, when you give for here, he has written non-asthmatic with food allergy, comes with severe respiratory difficulty after vaccination, does not improve with steroids. The answer is, they say, is suspect anaphylaxis and administer IM epinephrine. I would say that you suspect anaphylaxis, but take the blood pressure. And yes, if he is not responding, you might give him an IM epinephrine. Therefore, this is given in the book. Now, here are the differential diagnoses of an anaphylaxis. What are the differential diagnoses of an anaphylaxis? Syncope. How do you differentiate? We have discussed this. How do you differentiate between a vasovagal syncope and an anaphylaxis? Can you say?
Child,
Yeah.
child will have
Yeah. What is the essential difference between vasovagal syncope and the essential difference? I already said both can have. Usually, the child become very pale and has a thready pulse and a hypotension. He's unlikely to have a rash. He's unlikely to develop vomiting. He's unlikely to have a bronchospasm. Okay, these things. And the most important thing is, within minutes of raising his leg, he will become all right. Okay. Therefore, the first is syncope. Therefore, can occur in both syncope and anaphylaxis. Read the second sentence.
syncope is relieved by recumbency and is usually associated with pallor, sweating, and absence of urticaria, flushing, respiratory symptoms, and GA symptoms.
Okay. Therefore, you won't have bronchospasm. You won't have vomiting. But pallor is the important thing. Pallor can happen even in anaphylaxis, but first will be flushing. Okay. Next is, of course, we said respiratory asthma, acute severe asthma. Okay. Acute severe asthma, we already said, you read it.
Wheezing, coughing, and shortness of breath can occur in both asthma and anaphylaxis. Itching, urticaria, angioedema, abdominal pain, and hypertension are unlikely in acute asthma.
Okay. Therefore, that's a more. Now, what is the next differential diagnosis you have in your mind?
Anxiety.
Very good. Anxiety is a very good thing which you said. Okay. Anxiety is a very good thing you said. Anything more? You go and see a patient, immediately the patient is having, you gave an injection, black, he failed, he's on the cot. The mother and father are calling, he is not responding. You go near the patient, he is flabby, he is not moving much. There's a big commotion there. Anyway, hypotonic, hyporesponsive event. Okay. Rose, have you heard about it?
Yes, sir.
Okay. Gopika, you are there?
Yes, sir.
Okay. How's your daughter with you? Yeah, okay. Now, how do you differentiate between you people don't come for the class? You don't think it is necessary. But my question, Gopika, you keep coming now. Some other people are not coming at all. I am asking you a simple question. You go and see a patient. How the patient is on the couch, flabby, not responding. And how do you differentiate? Because if you diagnose anaphylaxis and give adrenaline, the patient cannot receive the immunization again. If you delay it, he can die. But if you diagnose hypotonic, hyporesponsive, it's only a precaution. You can continue giving the. Therefore, what is the essential difference between these two? I know I am not going fast enough. I may not cover the topic today, but I don't want you to come out as pediatricians without knowing this. You must know when to diagnose syncope, when to think of asthma, when to think of hypertonic. I don't blame you for not knowing this because this is not given in books. Hypertonic, hyporesponsive, one sentence. But then how to diagnose, how to differentiate it with anaphylaxis is not discussed at all. Is it important? No doubt, because anaphylaxis is a contraindication, and this high HHE is a precaution. Therefore, if you have diagnosed hypotensive, hyporesponsive, hypotonic event, you can make a diagnosis of it. Anyway, all right. Rose, can you answer that question? Okay, now let's go ahead and read it. Mimics of anaphylaxis, read it.
Mimics of anaphylaxis. While it is important to recognize and treat anaphylaxis, it is equally important not to label these other conditions as anaphylaxis, particularly when there are no objective findings. There are other more common reactions to vaccination that could mimic the anaphylactic reaction, including vasovagal reaction, anxiety-related symptoms termed immunization stress-related responses, ISRR. The term ISRR was introduced during the coronavirus disease COVID-19 pandemic, when this type of reaction to the severe acute respiratory syndrome SARS-CoV-2 vaccination was so common that an educational effort was begun to increase the awareness among the healthcare providers.
Okay, now this slide, I saw that actually when completing my immunization, just 1 hour before I go through the slides, I just opened the up-to-date and see if there is anything. There was a beautiful article, allergic reaction to vaccine, and it contains many things. I couldn't introduce everything. There I found for the first time the term immunization stress-related response. Therefore, if I am the examiner, I would ask you as a short what it is. Immunization stress-related reaction. Well, that is not there in any of the books, but I thought it was very useful. You read the next one.
Vasovagal reaction can mimic anaphylaxis because both may involve hypertension and collapse. However, the cutaneous signs and symptoms are usually quite different. With vasovagal reaction, fainting is usually preceded by pallor, whereas anaphylaxis often begins with flushing and may also include itching, urticaria, and angioedema. In anaphylaxis, tachycardia is more common than bradycardia, typical vasovagal reactions. In patients who report past fainting in response to vaccination, it is prudent to administer future vaccines while the patient lying supine and to counsel the parents patient prevention when going forward.
Yeah, it's actually better to keep every patient lying down when never on the shoulder. That's important. Remember, there are very fundamental things which they are telling. Both may involve hypotension and collapse. We have said this. This pallor and nausea, typical symptoms of vasovagal syncope, but child becomes pale and then collapses. Anaphylaxis, he becomes flushed. Flushed means his color increases, I think. And then later on, he can have pallor. That's another thing. Very important, anaphylaxis, tachycardia is more common, vasovagal syncope, because of the vasovagal action, vagal action, bradycardia is more common. I don't know how much of you knew all this. I was I was aware of it, but I was not fully aware. Now, it is not only the anaphylaxis and between anaphylaxis, generalized acute stress responses, and vasovagal reaction following. Therefore, there is something called anaphylaxis. We know. We thought about vasovagal syncope also be read now, but there is something called stress response. Stress response means is something less than a panic attack. This is very common actually for older patients who are already with anxiety. They may collapse on the body. You must know these differences. It's not given anywhere. This column is not given anywhere. I could read out. Given in up to date, and it's better you read fast. According, I think you read it fast. Okay. Gopika, you can read.
Yes, sir.
Yeah, read it now.
Difference between anaphylaxis,
What happened? I can't hear.
general acute stress response and vasovagal reaction with syncope following immunization.
Yeah.
Onset in anaphylaxis usually 5 minutes after immunization, but may be delayed up to 60 minutes. In acute stress response, sudden occurs before, during, or shortly after, that is less than 5 minutes of immunization. Vasovagal reaction with syncope, onset is sudden, occurs before, during, or shortly after immunization, may present after 5 minutes if the individual stands suddenly.
Okay.
In skin, in anaphylaxis, generalized
Can't hear. Gopika, I think your computer is not very good. Can Rose read it now? Can you read it?
Yes, sir.
Yeah.
And the skin in anaphylaxis, generalized urticaria or generalized erythema, angioedema, generalized pruritus with or without skin rashes, generalized prickle sensation, localized injection site urticaria, red and itchy eyes. In acute stress response, pale, sweaty, cold, clammy, and vasovagal reaction, pale, sweaty, cold, clammy. Respiratory, in anaphylaxis, persistent cough, noisy breathing, and airway constriction, wheeze, stridor, if very severe respiratory arrest. In acute stress response, hyperventilation. In vasovagal reaction, normal to deep breath. Cardiovascular anaphylaxis, increased heart rate, decreased blood pressure, circulatory arrest. Acute stress response, increased heart rate, normal or increased systolic blood pressure. Vasovagal reaction, decreased heart rate with or without transient decrease in blood pressure. GAT, nausea, vomiting, abdominal cramps in anaphylaxis, nausea in acute stress response, nausea, vomiting in vasovagal reaction. Neurological and other symptoms, uneasiness, restlessness, agitation, loss of consciousness, little response when supine or lying flat in anaphylaxis, and acute stress response, fearfulness, lightheadedness, dizziness, numbness, weakness, tingling around the lips, spasm of hands and feet. Vasovagal reaction, transient loss of consciousness, good response, one supine and lying flat, with or without tonic-clonic seizures.
Now you can't remember everything. At least you should remember this. One thing you have to remember is that when you have stress syndrome, even before the injection, the patient may start becoming pale and all that because he is very afraid of it. One thing you have to note is decreased heart rate is present only in vasovagal reaction because of the vagal, this one. And in patients who have anaphylaxis, you may have persistent cough, noisy breathing, wheeze, etc. But hyperventilation, typical, is which you've seen in generalized stress. But in vasovagal syncope, though it is maybe stress, it is normal to deep breath. Pallor is here, flushing, we have already said. Therefore, these, at least remember, there's something called acute stress response. One is, of course, which we very often see, the patient starts hyperventilating. This can happen in older children, maybe 5 years or 7 years. I don't think an infant will hyperventilate and become stressed. Okay, nausea can be present in all. Can you read it?
Anxiety-related symptoms. Vocal cord spasm can cause stridor and dyspnea, and panic attacks can cause global sensation, hypertension, tachycardia, dyspnea, and other symptoms.
I didn't know that anxiety can cause vocal cord spasm and cause stridor. I would have straight away diagnosed it as anaphylaxis. But they say that anxiety can also cause stridor. And panic attack is, I think, the most severe form. Globus, I don't know what is globus sensation. You know what it is? Globus sensation.
Foreign body sensation.
Sensation. Huh? Okay. I'm not sure about it. Okay. Now, my question is something here. We said something. How do you diagnose hypotonic? I'm sorry, I should have written hypotonic. Okay. That's a big mistake I made. What is hypotonic hyporesponsive episode? How do you differentiate it from anaphylaxis? It's not discussed at all in many things. There's a very difficult thing. Okay. Now, can you read it? It's given in the Piyush Gupta has given it. Can you read what is highlighted?
Hypertensive hyperresponsive episodes. Symptoms with acute paleness, transient decreased level or loss of consciousness, decrease or loss of muscle tone. Management with IV fluids and oxygen.
My God, he has written hypotensive. Huh? It is hypotonic. How can he write? He has made a huge mistake there in the PG guideline. That's why I also wrote on the top the same thing. It is hypotonic. 41. Somebody should point out to him because it is not hyper. The main difference between anaphylaxis and this is you don't get hypotension in hypotonic hyporesponsive episode. You understood that? You get hypotonia, you get hyporesponsiveness. The BP will be normal. The pulse may be slightly thready. That is how you differentiate between this. See here also, he says paleness, transient decreased level of loss of decreased muscle tone, IV fluids and oxygen. In anaphylaxis, acute decompensatory circulatory system. Okay. Hypovolemic shock. That's not present in hypotonic hyporesponsive episode. This catch my episode. This is a huge mistake if it is there. Therefore, now, if you look at the literature, if you go and say, okay, let me see how will you diagnose, how will it, hardly you will find anything. But finally, I came in information sheet of the WHO. Read it. What's given on the top? Rose, can you read it?
Hypotonic hyperresponsive episode.
Yeah.
A case defines an hypotonic hyperresponsive episode as a sudden onset of lameness and reduced responsiveness and pallor or cyanosis. In 1991, the review by the Institute of Medicine concluded that there was an insufficient evidence available to establish a causal relationship between wholesale pertussis vaccine and HHE. Although HHE occurs most frequently after wholesale pertussis vaccine, the reaction has been documented to occur after other vaccination, including diphtheria, tetanus, Haemophilus influenza B, and hepatitis B. The cause is not known, but recovery occurs spontaneously and no long-term sequelae have been documented. The majority of these infants can be safely revaccinated without a recurrence of HHE. In addition, the advent of acellular pertussis vaccine has markedly decreased the frequency of episodes of HHE.
Now you understand why I'm stressing on this, because the difference between this and the other is not very much. Okay. Both can occur: lameness, reduced responsiveness, pallor, cyanosis. These are very bad signs. The only difference is both are hypotonic, both will not respond immediately. They don't say how long it will take for the patient to recover. They are not telling that. Maybe it is transient. But what is not present in most of the case, except in one place I read, most of the case they'll say blood pressure will be normal. Therefore, when you are managing this, you take a blood pressure also. If the blood pressure is normal, is only hypotonic, hyporesponsive, at least you can say it's a suspected anaphylaxis, probably HSA. Therefore, the patient at least go ahead with receiving the vaccine. Now, go ahead now.
Which of the following has the shortest median time for exposure to cardiac arrest in anaphylaxis?
Okay.
A. Food. B. Insect venom. C. Iatrogenic medications. D. Latex.
Okay. Anybody wants to answer?
Food answer.
Food. Okay. You're all right. Okay. Can you
Answer C. Median time to cardiac arrest was 30 minutes for food, 15 minutes for venom, 5 minutes for iatrogenic reactions.
Now, the most important point to remember is whether to give adrenaline or not. But if you are given a vaccination, you have 5 minutes to give the adrenaline. You should have given adrenaline before the cardiac arrest. The longer you take to give, the less will be the impact of the adrenaline. And the dose after cardiac arrest is something different. Remember this. There are only 5 minutes to make the decision. And 15 minutes for a snake bite or some other venom. 30 minutes after food. You should have given the adrenaline before the cardiac arrest. That's the most critical aspect in the management of this patient. Okay. Can you read it?
Cardiopulmonary arrest. The time for exposure to allergen to full cardiopulmonary arrest varies. A British study found that median time to cardiac arrest was 30 minutes for food, 15 minutes for venom, 5 minutes for iatrogenic reaction. Epinephrine was administered only before arrest in 14% of patients, and all over, only 62% received epinephrine.
Remember, there's only 5 minutes for you, okay? And with all this teaching, with all these things, even in the Western countries, these are only 14% of the patient received epinephrine before cardiac arrest. Okay? Before, remember this. Maybe they came late, but even in the hospital, they didn't receive the epinephrine. What is the reason? Now I'll tell you something for you to understand. Now, suppose you what happens in the PRS hospital when the patient. Now, Rose, have you gone to your immunization clinic in Astor?
Yes. Yes, sir.
Is there a doctor inside that?
It's nearby the OPDs only, just nearby the OPDs.
Okay, that's fine. That's what's happening in PRS also. But sometimes, suppose the doctor has gone on a call or gone for tea or something, the patient gives, the nurse gives and develops anaphylaxis. Will she give the adrenaline?
Only after the prescription by a doctor only.
By the time, should she be giving the adrenaline? A&M is going and giving vaccine all over the place. Does she carry a adrenaline, or will she give it if the adrenaline is given, if it is necessary? Does she carry an adrenaline packet? Is she entitled by the Nurses Association to give the adrenaline, emergency medicine? Life-threatening. You have to give it within 5 minutes for an injection. You can't call the doctor. I asked this question many, many times. IAP, IMA, I asked it. Nobody has the answer. I asked whether the nursing council gives the nurses the right, forget the AN, nurses the right to give the injection without a doctor, because it may not be possible to get the doctor. You call the doctor, she should come running, and then she should order. It is definitely going to take time. And when you are giving at home, A&M is giving at home, please inquire about this, okay? And you know what happened in PRS? I wrote and gave. I would like to know what is the situation. And they said, finally, the matron said, let Dr. Padmanabhan give in writing that the nurses can give injections in emergency. Am I right? Am I anybody to... There should be a policy for them. They don't even think about it. Remember this. They don't even think about it. That's a vital matter like this. Therefore, whenever you send immunization abroad, whenever you go for anywhere where immunization, make sure there is adrenaline. The adrenaline has not expired. At least you have 3 vials with you. And what else we will come to when we come to the management. Okay. We are now going into adrenaline.
What is the mechanism by which adrenaline helps in anaphylaxis? A. Inhibit histamine synthesis. B. Act as a mast cell stabilizer. C. Causes vasoconstriction, bronchodilation, and inhibit mediators release. D. Blocks IgE receptors.
What's the answer?
C.
B. Everybody agrees?
C.
You changed that. Okay.
Sir.
What's the difference between epinephrine and adrenaline?
Same.
Same. Epinephrine is given in America, they call it epinephrine. In fact, they call it epi. And for the British, they call it adrenaline, and we are more familiar with it. Now, this is the answer. Read it now.
Epinephrine has both alpha sympathomimetic and beta sympathomimetic action, causing a peripheral vasoconstriction, increased cardiac output, and bronchodilation. It is the only drug that inhibits the further release of inflammatory mediators.
That's the most important point. Adrenaline is the only drug, not even hydrocortisone, not even antihistamine, nothing. Glucagon, nothing. It's the only drug that inhibits further release of inflammatory mediators. And in a case of immunization, it has to go in within 5 minutes. If it doesn't, if you have not given it, you have not treated. Whatever else you did, you are not treated. Now, what is alpha symptomatic, beta symptomatic? You might be knowing. Shall I skip it? Because I'll put it on the this one. You must be knowing what is alpha 1, what is alpha 2, etc. I'll skip it. Beta 1, beta 2, I put it up just for knowing how does alpha 1 receptor act, alpha 2, beta 1, beta 2, etc. Therefore, summarizing the key differences in the defect. When I put it in the video, if you have time, you can go through it. Therefore, we will go to the acute management straight away. Okay, read it now.
Acute management. Epinephrine is the first-line treatment for anaphylaxis according to all guidelines. It has both alpha sympathomimetic and beta sympathomimetic action, causing peripheral vasoconstriction, increased cardiac output, and bronchodilation. It is the only drug that inhibits the further release of inflammatory mediators from mast cells and basophils.
That's the most important action. Okay.
Can be given even when diagnosis is suspect and in cardiac patients. If shock is imminent or has already developed, epinephrine need to be given by slow intravenous infusion, ideally with the dose of titrated according to non-invasive continuous monitoring of cardiac rate and function.
Do you have the chart how to give adrenaline infusion or magnesium in the ICU now, PICU? Gopika, do you have it in your PICU? Gopi has disappeared. Lasim has disappeared. Mohsin has disappeared. Okay. Faris, do you have it in PICU?
That is there, sir.
Huh? Mohsin, you are there.
Yes, sir.
Why you're so... I can't hear you only. Okay.
You are raised, sir. Don't
Huh?
able to read that. You are raised.
Okay.
You are.
Okay. Now, Rose, do you have it in your ICU there, PICU? You should have it. Okay.
Yes, sir.
You should have it how to give adrenaline. It's not a joke how to give this medicine. Therefore, this is the reason. Acute management, epinephrine is the first line treatment. Okay, now.
Which of the following is true statement about delayed, that is biphasic reaction in anaphylaxis? A. They occur in less than 1% of cases. B. They typically occur within 1 to 2 hours. C. Median onset is 11 hour, range 0.2 to 72 hours. D. Steroid prevent biphasic reaction.
Yeah, what do you say?
Median onset is 11 hours.
Yeah, okay, very good. That's a biphasic action. You know, what happens is you have a first and then you send, okay, see what happens. I'll tell you now. I'll tell you what happens. Will prevent this. Okay. And no evidence that steroids will prevent this. What happens many times is, if especially in the health service, when a patient develops a reaction and you think you gave an adrenaline, you think anaphylaxis, you somehow want to get the child home. ഒന്നും സംഭവിച്ചില്ല പേടിച്ചു പോയി. I mean, he became very afraid because the people will accumulate around the health center. If the patient is still there, you want to discharge him. Normally, you will discharge him within half an hour or 1 hour and say he was only afraid, it was a syncope, nothing. You won't admit him because admission, then it becomes serious matter and so many inquiries will come. But remember, there can be a biphasic reaction. And what is biphasic reaction? The onset is 0.2 to 0.72 hours. Now, if you have an anaphylaxis and you are given adrenaline, how long will you keep an adult? How long will you keep a child? Will you admit him? Rose?
It's advised to keep the child for 6 hours observation at least.
All right. What do you say, Mosul? With your URI, you can answer. You have seen a patient, the doctor calls from the ER and says, doctor, came with shock after immediately I gave adrenaline. We even tried to give him some cardiac med. Now he's okay. It looks like definite anaphylaxis. They have documented it as anaphylaxis. And this is a child. Mohsin, how long will you keep? What will you do? You will call the consultant. The consultant says, anyway, the child is all right. Don't make a big issue of it. Send him home. What do you say?
Sir, keep for observation, sir.
Observation or
Recur.
admission? Observation. These are all medical legal. Admission or observation?
Get counsel for admission also.
What do you want to do? First, you should make up your. See, if a Faris goes to the health center, he calls up the district hospital and say, patient is okay. I'm sending the patient by ambulance. The pediatrician there will shout back, help with you. Why do you want to put it on me? Child is okay. Keep him there for 4 hours and send him home. Read it now. Okay. This is from the. Okay.
Delayed or biphasic reaction in anaphylaxis.
Yeah.
Defined as a recurrence of symptoms within 72 hours of initial anaphylaxis without a re-exposure to the trigger. Can occur in up to 20% of patients who develops anaphylaxis and could involve organ symptoms. Symptoms not affect in the initial reaction. No evidence steroid will prevent this. No more common where hypotension was present at the initial reaction, and this is unusual in food-induced anaphylaxis.
Okay.
Around
I forgot. I missed something. Yeah. More common in hypertension. Okay. Yeah. Start it.
Around half of biphasic reaction occur within the first 6 to 12 hours following reaction. Patient with anaphylaxis need to be observed. This is important, especially in severe reactions and those requiring multiple dose of epinephrine. The median time to onset of biphasic symptoms was 11 hours, range from 0.2 to 72 hours. That is 50% of reaction occurred more than 11 hours after initial reaction. This is relevant because current guidance from the National Institute of Health and Care Excellence recommend the patient over 16 years are observed for 6 to 12 hours after anaphylaxis. Children under 16 should be admitted.
Therefore, for your own sake, if it is under our children, if you have documented it as anaphylaxis, you are given adrenaline, admitted. That's my observation, because you can have a biphasic response. Rose, did you know that? Hello, Rose is gone, I think.
Illa, sir.
Yeah, this is very, very important because even your consultants may not be fully aware of it. Children, as per NICE guidelines, should be admitted. Now, is there a guideline? No. Does the IAP talk about it? No. But biphasic reactions are known. If you send the patient home and he dies at home, the inquiry will be ordered, and then the doctor, pediatrician, the DMO will start reading everything about it in the book, come back in the inquiry. The first question is, Dr. Rose, did you know that there was a biphasic reaction? At that time only it will come to your knowledge. You understood? Therefore, there is especially when there is hypotension, you should observe for, and children below 16 should be admitted. All right, this is not given anywhere else, but it's better that way. If you are in the ER, you are calling up the consultant says, send the patient home, no problem. Tell him, sir, Dr. Padmanabhan sir taught us like this, given in archives. Go to hell what he says, send him home, tell the consultant, I am writing that you have instructed me to send home. I am sending home. I am worried about biphasic reaction. If you are transferring the patient, the other person says there's no need for admission, tell him for biphasic symptoms, you are supposed to admit him. But I observe for at least for 24 hours. If you are saying no, I will document it and cancel the referral. Okay. Now, carry on now.
A patient present with tachycardia, flushing, and gastrointestinal symptoms are after the bee stings. There is no urticaria. Can anaphylaxis still be diagnosed? A. No, because there is no rash. B. Yes, if airway, breathing, or circulation is compromised. C. Only if tryptase is elevated. D. Only if IgE is positive.
What's the doubt?
Yes.
He has got tachycardia, flushing, and gastrointestinal symptoms of a bee sting. It is a known, this one, is it not? Bee sting is a known allergen. It's not known to the patient, but it's a known allergen. Rose, what do you say? I'm surprised you are not
B.
answering.
B.
What?
Yes.
Yeah, because here,
Sir.
tachycardia, flushing, and gastrointestinal symptoms. Flushing, tachycardia is taken as a symptom of hypotension, probably. For airway, breathing and circulation is compromised, definitely. Okay. You can
Answer.
read the answer.
Severe anaphylaxis is characterized by a potentially life-threatening compromise in airway, breathing, and/or circulation, and may occur without typical skin features.
Therefore, we have already seen this definition. I am not going to go through this again. Okay. We have gone through this. Anyway, we have discussed this way. Okay. Key to diagnose the rapid development of the symptoms, rapid progression of the symptoms. Now, read this answer. Question, please.
What is the case fatality rate of anaphylaxis? C.
Okay, we read it already. Many reactions are not treated appropriately. A fatal anaphylaxis is a rare event. I will summarize anaphylaxis like this. It can cause death. It can cause problems, which not only for you, you cannot escape from it. It's a huge medical legal problem it can give. But luckily, or unlikely, I would say the case fatality is very, very rare, even though it is often and very often not managed. No adrenaline is given within 5 minutes. Nobody dies of, but when it dies, people will say, we have been given the vaccine for years. One pediatrician will say, 40 years I gave vaccine, not a single child developed anaphylaxis, but it can, and therefore it is 0.001%. Remember, when you are called to see a patient, I repeat again, a child has developed some problem, stop everything, go to the patient, stand by the side of the child, put him supine, raise the legs, shout for adrenaline and help. And then when the adrenaline comes, if the patient is still unconscious, and by the time try to check the BP is low, the patient has had a DPT injection, which is a known allergen if we have, straight away give him an adrenaline at the lateral spot. The moment you receive it, you give it. That's a better thing. Later on, you can say that it was a suspected anaphylaxis as per definition of the NICE guideline. Better to err on the side of giving adrenaline for your own sake and for the patient's sake, immediate sake. For the long term, it can have consequences. Okay. We have gone through this. We have seen that's 0.001%. Okay. Now, this is a very important thing. You read it.
Anaphylaxis often result in death. Therefore, the majority of anaphylaxis reaction cannot be described as life-threatening in themselves. Given our inability to predict reactions progression, it is emphasized that all anaphylaxis reaction must be appropriately treated with intramuscular adrenaline to help reduce risk of death.
Okay, therefore that's one. If you develop a rash, the child becomes more sick, tachycardia, he's not responding, becoming more paler, the BP is dropping, give the injection. Some people may say, doctor, you could have waited. Now you have painted him. No, you have to give it we cannot predict the progression. Initially, it may look very simple. It may progress very rapidly. Or it may cause hypotension, everything. He may recover also. Okay.
A child developed vomiting and fatigue 3 hours after vaccination and was brought to ER. Now he is well. What would be done before administering the second dose?
On the second dose, what he mean here is a little confusing. The child this very common happens. He come to the after vaccination brought to ER. He had after 3 hours he developed vomiting and fatigue, and this can happen. But he responded. He is. He has. Therefore, is it anaphylaxis? That's the question. Therefore, the answer you give. Which will you do now?
Administer vaccine under observation for 1 hour.
Yeah. Okay. See, is it the second? We are talking about the second dose. We are not planning to give immediately. If it is anaphylaxis, the second dose will be very dangerous. Is it anaphylaxis? Will you suspect anaphylaxis in this condition? Very tricky situation. You understand that the patient recovered by himself and it occurred after 3 hours doesn't mean that the patient did not have anaphylaxis. He developed vomiting and fatigue. Well, I would go with what Rose says, but what the answer patient says last time vomited several times, became brought is suggests possible delayed anaphylaxis, caution needed. Therefore, they are telling avoid second dose and refer for allergy evaluation. But that is not possible in our country. Maybe it is possible in other countries. Therefore, it is a very difficult situation when the patient comes, ask your consultant and do whatever she says. But I would definitely bring the child back, give him the hospital, give an injection and observe him for a day. All right. Now, this already again and again I'm coming to this because of the importance. Now, go back. Read this.
Which of the following is a key diagnostic clue for anaphylaxis? A gradual onset over days. B. Sudden onset of symptoms after exposure to a trigger. C. Isolated gastrointestinal symptom. D. Improvement with antacids. Option B.
Okay, there's no question. The key diagnosed pattern, sudden onset of characteristic symptoms after exposure. That's a very important point. Rapid progression, sudden onset. These are, though there are diagnostic criteria, the key is the rapid progression of the symptoms. Okay.
What is the role of IV antihistamines in anaphylaxis? A. First line treatment. B. Can replace epinephrine in mild case. C. Adjuvant therapy only, not life-saving. D. Prevent biphasic reaction.
I gave the answer also. Antihistamine is supposed to be replaced, can adjuvant therapy only. You can give antihistamine along, but you should not be the main first treatment. It's not the first line, like many people believe. Let me give antihistamine and then see. No, if it is anaphylaxis, give epinephrine. But along with that, you can give antihistamine. is an adjuvant therapy. You can give H1 antagonist of administering, etc. That's what is given here. We have read this slide before. Histamine is only one of them. Oral histamine take about 30 minutes. IV chlorpheniramine, which is Benadryl, is not available for us. I think promethazine hydrochloride is available. A prophylactic use does not prevent anaphylaxis. Okay.
Which of the following findings would favor a syncope over anaphylaxis? A, hypotension relieved by lying flat, presence of urticaria, bronchospasm, abdominal pain. Yeah,
Okay, that we have already said that very many times. We have said syncope, we have discussed this. Okay, now come to this.
a child with anaphylaxis remains hypotensive after IM epinephrine. What is the next step? A, IV fluids and consider a slow IV epinephrine infusion. B, repeat IV epinephrine every 5 minutes. C, start oral prednisolone. D, nebulized adrenaline only.
Okay, by this time you would have called the PICU. The PICU doctor would be coming, running. But what will you do before that time? One epinephrine, the patient became better. Doom, again the blood pressure starts going down. What will you do? Mohsen, what will you do?
Yeah, give IV fluids. Another dose of epinephrine can be given after 5 minutes. Another
Okay.
1 dose.
So what is the
And
answer?
the fluid can
What is the next step they are asking?
IV fluid. Consider IV
Okay,
fluid.
okay, that's the next step. Okay.
If shock is imminent or has already developed, epinephrine need to be given by slow intravenous infusion.
So what here is the answer you have to think about is what's the next step immediately. Therefore, what Mohsen said is right, slow epinephrine infection. But this is also right. IM epinephrine, once you give, you have to repeat it every 5 minutes. Okay. If you read it here carefully, if no improvement, repeat intramuscular every 5 minutes. IV fluid challenge. You have to give IV fluids. And then inotropic support may be ineffective in the absence of adequate fluid resuscitation. Therefore, the first thing is IV fluids, and then you start epinephrine inotropic support is next. Okay. Give a fluid 20 ml per kg, push. BP is low, push. Wait for 5 minutes for the next adrenaline ion. Start the adrenaline drip, make the drip. Therefore, everything should be in your mind very clear. Okay.
Which of the following is common trigger for anaphylaxis in children? A, common cold virus. B, peanut milk egg. C, acetaminophen. D, iron supplements. B, peanut milk egg.
Actually, peanut milk and egg are supposed to be the milk is supposed to be allergy. Egg allergy is common. Peanut is supposed to be very important in the Western world. Rose, what is the importance of peanut allergy from other nut allergy?
It's very serious than the others.
Why? How is it serious? You can die of eggs allergy, anaphylaxis also. How's peanut different?
It can start from very younger age.
All right.
Family history will be there.
See, in other allergies like egg and others, you may grow out of it. Peanut allergy is usually lifelong. That's the one thing. And they used to see it can be so serious in Western countries. If the mother eats peanuts and kisses the child can develop anaphylaxis. Now, you have a what you call as egg allergy in the mother, severe family history of egg allergy, or you have severe allergy to peanut in the family. Now, what will you do when will you introduce the nuts in the child? Normally, peanuts are given only at 2 years or something. Nuts you should give later because he might aspirate, etc. But if you can, when can you give an allergen food to the child? Rose, can you answer?
Early introduction is advised now.
Yeah, that's the most important thing. That is, nowadays, if a child is allergic to something, try to introduce him at the earliest. That's the difference from previous. Yeah. Now the question. Yeah, read it.
How long should a child with severe anaphylaxis be observed in hospital? A, 1 hour, 2 hour, 6 to 12 hours until trypsin is normalized. 6 to 12 hours.
Okay.
Current guideline recommend patient over 16 years are observed for 6 to 12 hours after anaphylaxis. Children under 16 should be admitted.
Okay.
Which of the following is true about National Institute of Allergy and Infectious Disease criteria for anaphylaxis? A, 100% sensitive and specific. B, can be used in place of clinical judgment. C, have 97% sensitivity and 82% specificity. D, should not be used in children.
Is a very important thing. It's a very important. Now it may look very simple on the face. This Rose, we are taking opinion from your places. Nobody has the answer. Is it why? Yeah, See, even the National Institute of Allergy Infectious Diseases, they say it's only 97% sensitive. That means 3% it may not detect. 82% specific. Therefore, whenever you go for an inquiry or whenever somebody asks you, Doctor, are you so sure that you gave adrenaline and the patient had anaphylaxis? You must tell her that the diagnosis of anaphylaxis is clinical and the best, what you call criteria is not 100% specific. It is only 82% specific. Therefore, if you look at the top of the diagnosis, it's clearly written there, anaphylaxis is likely, mostly likely, is not written. It is a clinical diagnosis, it is not definite. Therefore, even when you are suspecting anaphylaxis, the question is, when will you give the adrenaline? I gave the adrenaline. But by definition, this is anaphylaxis. But according to NICE guideline, you have a place to say that suspected anaphylaxis. And no diagnosis is 100% specific or 100% sensitive, including the nationals. It's very important when you go for an inquiry. Read it now.
No set of diagnostic criteria for anaphylaxis will provide 100% sensitivity and specificity. The criteria developed by the NIAID panel in 2004 have been shown to aid the diagnosis of anaphylaxis. The accuracy of these criteria were retrospectively evaluated in an ED setting and found to have 97 sensitivity and 82% specificity. The negative predictive value was 98% and the positive predictive value was 69%, showing that a significant number of patients who met the criteria might not have anaphylaxis.
See how it is. Now that's why in Western countries they want you to take the tryptase. Now remember this. You may ask, why is the WHO criteria not put? What is the sensitivity? It's not done. It is this which has been very much tested. Okay. Now we go to the next.
A child developed urticaria and flushing within minutes of the second COVID vaccine dose. With a history of severe anaphylaxis to the first dose, what should be done? Observe and give histamines, administer IM epinephrine immediately, discharge with auto-injector prescription, wait for bronchospasm to develop.
Mohsen,
B, sir.
B. Okay, see, the thing is that if you are a known allergen to the patient, the moment you develop urticaria, that is enough. Okay. I am known. Don't wait. Don't say that let me develop bronchospasm. He's not meeting the criteria. He's not meeting the criteria. He's a known allergen. A patient, second dose of the first dose, he has developed anaphylaxis. Therefore, it's a known allergen to him. give him epinephrine. Don't wait for the diagnosis. Okay? Read it.
Patient with anaphylaxis can present with symptoms not meeting criteria, yet require epinephrine. History of severe anaphylaxis.
Okay. Can you read this? These are very simple questions. We'll go through fast.
What is the most important reason for immediate epinephrine administration in anaphylaxis? A. It prevents further allergies. B. Delayed administration is associated. Delayed administration is associated with poor outcome and mortality. It replaces the need of hospitalization. It prevents heart biphasic reaction.
Quick. Rose, what's the answer? I was
B, sir. B,
Yeah,
sir.
yeah. This is what I was stressing. To give or not to give is the basic question. Adrenaline is not a question of diagnose alone. You have to act fast. You give fast. If you give, then the question rises. You have put your finger down and said it is anaphylaxis. Will you give the second dose? Everything becomes associate poor outcome and mortality. What's the next question here?
Which of the following is contraindication to IM epinephrine in anaphylaxis? History of hypertension, cardiac disease, none, no absolute contraindication, age less than 1 year. C, no absolute contraindication.
Yeah, because we are driving home some of the important points. In the setting of anaphylaxis, there's no contraindication. Okay. Now, about guidelines, we have said it's only drug. We have said all this. Okay. The first and most important therapy in anaphylaxis is epinephrine. There is no absolute contraindication to epinephrine in the setting of anaphylaxis. And also remember, medical legally, if you are not given epinephrine, you have not treated anaphylaxis. Okay, read it now fast.
Delayed administration of epinephrine is associated with poor outcomes and mortality. Patient with anaphylaxis can present with symptoms not meeting the criteria for anaphylaxis and yet require administration of epinephrine, such as a patient with a history of severe anaphylaxis, first COVID injection, who was inadvertently given second dose, and within minutes is experiencing urticaria and generalized flushing.
Therefore, he has not met the criteria of anaphylaxis, but you will give it because he has already once received, he has already passed history of anaphylaxis. He's a known allergen to the patient, not to the population. If he develops any symptom, you will give adrenaline. Okay.
What is the recommended dose of IM epinephrine in children with 20 kg? 0.2 mg.
Very good. Yeah. 0.01 milligram per. See, doses in pediatrics are not supposed to be by hearted. But emergency medicine, they can ask you. That was the principle in, I don't know what is it in your national board. Emergency medicine, they can ask you. For the dose of ampicillin, dose of ceftriaxone, dose of meropenem, they are not supposed to ask you. But you can't say about examiners, they can be very different. Okay. Now remember this one thing. This is a very important thing. There is a lot of slip between the cup and the lip as well as adrenaline. We teach, we preach, but ultimately the child doesn't get. Now, what is the dose below 1 to 5 years? Even below 6 months, the dose is 0.15 ml. 1 by 1,000 adrenaline is the one which is available. What does 1 by 1,000 mean, Dr. Gopika? Can you
1
tell?
by 1,000 is the undiluted form.
Yeah, 1 by 1,000 means, why is it called 1 by 1,000? One, what is 1 here? And what is 1,000 here? It is actually 1 gram in 1,000 ml. Okay. Therefore, 1 ml will contain 1 milligram because 1,000, how many milligram make a gram? 100 or 1000? Remember this. This is the standard which is available. In newborn, do you have 1 in 10,000? In newborn, you are supposed to have 1 in 10,000. I am not sure about it. Now you are having adrenaline. Great. Remember the dose. Okay. 0.15 ml below 5 years. 0.3 ml and 0.5 ml. Therefore, how will you give it? Dr. Rose, how will you give it? You are ordering, sister, give 0.15 ml. Sister will say, I have 0.2 ml, doctor. How will I give 0.15 ml? What will you say? Huh?
In tuberculosis.
Tell it quick. Well, I went and taught the emergency doctor, emergency nurses, please keep a tuberculin syringe. You have seen a tuberculin syringe, 1 cc, it has got 100 marks. Then I asked the nurse in the ER, you see, many times the nurses are more intelligent than you. I asked her, do you have a tuberculin syringe? She said, no. Therefore, I asked her, how in the hell are you going to give for a child? You forget our children. She said, what's the problem, doctor? I have a, what you call a 10 ml syringe. I will take 0.5 ml of it, draw it in 10 ml, and give 1.5 ml. She said something like that. I was really surprised that it didn't strike me. But this is very important, you know, unless you, it is very simple to say 0.15 milligram. How are you going to give it? The nurse there may not be a pediatric nurse, and she might ask you, how, doctor, am I going to give? The best thing is to have a tuberculin syringe. If you don't have it, the normal 1 tuberculin, 1 ampule is 0.5 ml. You dilute it in 5 ml, and then you make the corresponding ml, or whatever you want to give, you give. That's the only way out. Therefore, it is written here many important practical points. Children older than 0.5 ml, 6 to 12 years, 0.3 ml, and 0.15 ml here. And 25 millimeter, see, you are not giving subcutaneous. You are not giving like in an asthma subcutaneous. You are giving IM. Therefore, a 25 millimeter needle is best suitable for all ages. In preterm, a 16 millimeter needle is suitable. In some adults, a 38 millimeter needed. You had to give it IM and not subcutaneous. Therefore, remember, you don't pinch it, the skin. You flatten it out and then give it so that it goes straight into the muscle. These are important because what you're giving is a life-saving medicine. All right? Okay. The dose you should know 0.5, 0.3, 0.15 ml. Okay. Now, this is, if you are in the pediatrics, print this out and keep it in PICU, please. Print this out, how to give an epinephrine infusion. Okay, it is in up to date. How to give it is not easy. Therefore, these things you should print out, keep it in ICU. If I remember, I had kept it. Now I am no longer in PICU. I'm not interested in that. And example of preparation of epinephrine infusion. I've given it in here. Pediatric dose, how you give. You must know it very clearly. It's not easy. When the patient is in shock, it will be absolute confusion. Unless you have print, you cannot. Now, my question to you is angioedema, what will you do? I told you angioedema means, read it out. Can you read?
Angioedema is the swelling of deep.
Yeah, Rose, you read it.
Angioedema is the swelling of deep dermis, subcutaneous or submucosal tissue, often affecting the face, lips, tongue, and eyelids, genitalia, hands, and feet. Less commonly, submucosal swelling affecting the bowel or airway.
What happens when there is submucosal swelling bowel? You develop abdominal pain. When the airway, you develop stridor. Then it becomes anaphylaxis. Now, my question here is: you have angioedema. You know, you just have urticaria. Sister, I would give him a Phenergan. That's enough. No, he develops swelling of the eyes and lips, angioedema. What is the treatment? You must stand by the patient and give these things. He has not developed anaphylaxis. Is a second or first dose of kit. It is a known allergen, but it is not a known allergen to the patient. If it was a known allergen to the patient, like you are given the first vaccine DPT, he had collapsed, anaphylaxis, second dose, he develops angioedema, even urticaria, you will straight away give adrenaline. But here it's a known allergen like immunization, and he's just developing angioedema. What's the treatment, Rose?
Angioedema, antihistamines.
Okay, read it.
Categories includes allergic angioedema, non-allergic drug reaction, usually caused by angiotensin converting enzyme inhibition treatment, hereditary angioedema, acquired angioedema, and idiopathic angioedema. Angioedema and anaphylaxis both involve histamine and or bradykinin. However, in anaphylaxis, the reaction is more marked, resulting in an increased vascular permeability and subsequent circulatory collapse.
Okay, the moment you develop a circulatory collapse or then the blood pressure drops, it becomes anaphylaxis, and you'll straight away give him a adrenaline. Before that, see, what is hereditary angioedema? Hereditary angioedema is conditions in which C1 esterase deficiency is there. They will come with different abdominal pain and urticaria. The difference between allergic urticaria, there'll be no itching. Therefore, whenever you find urticaria and no itching, suspect hereditary angioedema. Okay. Without anaphylaxis, what's the treatment now?
For people with rapidly developing angioedema without anaphylaxis, low IV or intramuscular chlorpheniramine and hydrocortisone should be given and emergency admission arranged.
Well, there's no
For
adrenaline
people
in
with
that, but it should admit it. Okay. With stable angioedema, yeah.
For people with a stable angioedema without anaphylaxis,
Yeah, this is what happens many times. Comes with swelling of the eyelid. You think it is nephrotic syndrome. You do a urine, it is normal. He has some itching rashes. Therefore, it is there for 2-3 days. Therefore, you can give him the antihistamine. Read it.
the underlying cause could be identified and removed where possible. A non-sedating antihistamine should be offered. For severe symptoms, a short course of oral corticosteroid should also be offered. Referral to an immunologist or a dermatologist should be arranged if the cause of angioedema is not identifiable.
Or avoidable. Okay. And what is the non-sedating antihistamine you can offer? Okay, read it.
In children, cetirizine, loratadine, fexofenadine are usual choices and have been well studied. The British National Formulary for Children states that desloratadine or levocetirizine should be reserved for children who cannot tolerate other treatment because they do not confer any additional benefits.
If cetirizine enough, lotadine is enough, fexofenadine is enough. And the latest British formulary is always like that because it will be very costly. The latest drugs, they don't like to use it. Anyway, for a patient who's stable, 2-3 days, you can just give oral antihistamine. For a patient who's developing rapidly the angioedema, you give hydrocortisone and IV antihistamine. The moment he develops bronchospasm, you give adrenaline. Bronchospasm, or you develop shock or severe gastrointestinal symptom, you diagnose it as anaphylaxis and give him this. Last question. Okay.
A child collapsed 1 hour after vaccination with thready pulse and respiratory distress, but no rash. What is the diagnosis? Anaphylaxis.
Okay.
After vaccination, 1 hour suddenly collapses, thready pulse and breathing difficulty, no rash.
Okay, I think we have finished our com. We have overstepped by 20 minutes. That stop here. Recording, I'll stop now, 1 minute.